I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Monica Soni, Associate Chief Medical Officer of New Century Health. She's here to talk about time toxicity. Dr. Soni, I'm really excited about this topic. Thanks for speaking with me today.
Oh, I'm so pleased to be here. Thank you for having me.
It's a pleasure to have you. So let's get started. Please talk about your background and your work for New Century Health.
Absolutely. So I'm an internal medicine physician. So I'm a little bit of a masquerader in New Century Health, which manages risk, mostly in cardiology and oncology. But I feel like a doctor that's worked in outpatient and inpatient settings. I really bring a specific perspective, which is about how to center the patient at the middle of care. So I work cross-functionally in the organization, supporting a lot of our Medicaid plans. I'm really thinking about our highest vulnerability populations. I advance our quality agenda, our health equity strategy as well, and just try to make operations smoother for everybody here.
Well, in an article you wrote for STAT, you talked about the need for clinicians to be honest with cancer patients about their outcomes. Can you expand on this?
Yes, and it's tricky. I don't want to imply that physicians are not honest. I think that we soften language quite a lot, and we use euphemisms, and the way that you talk in the break room with the physicians or with the residents that are in training is so different than the way you speak to patients. And it should be, right? Like you should bring your best bedside manner. But where I start to get worried is when we're not actually giving the full information to patients or the full picture. And it's their body, it's their life. And so there was this sort of unbelievable study that looked at oncologists and their patients. The patients all had metastatic advanced disease and we're not going to survive that cancer. And they interviewed both sets and they said, how long do you think the patient's going to live? And they asked the patient, how long do you think you're going to live? They asked them things like, do you have cancer that can be cured or not? And the oncologist and the patient's understandings were opposite.
Wow.
Huge swaths of the patients thought that they had curative cancer and were going to live more than 5 years. And the oncologists were like, no, they're not going to live more than 5 years. None of them, 0% of them are going to live more than 5 years. They have metastatic cancer. This was published in JAMA. And it just sort of blew my mind. And when I really thought about that article, I said, of course, because we're not that clear with patients about their prognosis. We're uncomfortable talking about it. Sometimes patients and their families are nervous, of course, to hear the information. And so I just felt very passionately that we could do better.
Well, how does one even begin to have such a conversation with a patient? For example, I have a friend who he's got metastatic pancreatic cancer. He was diagnosed more than 5 years ago, and he's still alive today. I mean, he does his weekly infusions, but he's still alive today. Yep. So, I mean, doesn't that kind of conversation require nuance?
Of course, 100%. And I would say, we're not God and we should never play God. And so we'll never be able with certainty say, this is the day that you're going to die, or this is what's going to happen to you. But we do have a lot of studies and statistics. And so we can certainly say, patients like you, patients I've cared for like you, patients that have this certain circumstance, here's the probability, here's the likelihood of things happening. We can ask permission to talk about what does it look like when you actually are in the last 3 months, 6 months, 9 months of a disease like metastatic pancreatic cancer. And you can work with patients on what their goals and wishes are so that you can make sure that at every step of the way you're meeting them. But the first thing has to start with, you can't be afraid to talk about whether or not this disease is likely to kill you or not, right? You have to at least have that shared level of understanding to start with.
But do patients understand that when they get such I mean, getting that information to begin with is such such a burden, right?
Yeah, shattering.
Shock to your system.
Yes.
You see in the movies when they say you have cancer and the next thing you hear the person goes like, whoop, 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 because like you don't hear anything anymore. It just all goes to the background because you just received this like ton of bricks. When you say that doctors should talk statistically, do patients understand that?
Yeah, and I'm obviously using more technical terms with you, but that's not how you talk by the bedside. And your point is so well taken. We as physicians are on 15-minute, 20-minute increments. We had a list of things we want to get through, and you sort of just blow through it. Even if you're kind and gentle and caring, your agenda is not always the same as the patient's agenda. So I would say it's not a singular conversation. I think you write things down, you ask loved ones, caregivers, whoever else is important to the person to be there too. You take it into pieces. Like I said, you ask permission for how much they're ready to hear and when, and then you go from there. It doesn't have to be a one and done. And I think that's the other problem is sometimes it's a checklist thing for us and it's kind of like a one and done. I
Right.
talked to them, I told them it was metastatic cancer already. Many physicians will say that. And that's not the way that the conversation can happen for all the reasons you just articulated.
What is time toxicity?
Yes. I'm so excited we're talking about this because
Ew.
in in the oncology space, there's been a lot of focus on obviously clinical toxicity, the side effects, things that land you in the hospital, make you feel crummy, financial toxicity, right? Just breaking the bank, medical bankruptcy. And I think this third pillar of time toxicity, there's been more and more recognition of how important it is to think about. So there was a study that looked at patients with pancreatic cancer who got surgery and mapped out of the days that they had alive, how much time was spent in the clinic, at appointments, getting labs done, getting imaging done versus spent outside of those settings. And it was really an underestimate, but they were like, probably 10% at least of alive days are spent in a medical setting. And then people started to say, that's a way underestimate. How about the driving? How about the parking? How about the loved one that has to take off to come with you? How about the day after the infusion where you feel so crummy that you can't do anything anyway? Or the urgent care visit that you had that wasn't captured in there because you were so nauseous and vomiting. And so this idea to me is a very patient-centered measure. It's for us as physicians and clinicians to think about when you talk to patients about their wishes, if they say, I want to spend as much time as I can with my family, living a high quality of life, we better be thinking about the time toxicity, right? We better think about not just, okay, how do I have you have some extra, days or months of life? Not just how do I, diminish the amount of physical toxicity you have, but how much time is that going to take from you as well? So I really love this because it forces us as clinicians to think a little bit outside of the box versus, again, more like cookie cutter medicine. I'm going to do this and then this and then this. If someone says to me, I really don't want to come back next week or the week after, or I'd like to spend a whole month away from you all, I'm tired of being in the hospital. How do we maintain outcomes and still deliver care with that mindset?
There's also the conversation that I imagine some patients have to have with their boss, like, hey, you've taken off all of this time. I'm going to dock you or I'm going to fire you. That's
Yes.
another thing that we don't think about when we talk about time toxicity.
Oh, yes. And so the one area I've been really kind of digging into is this idea of hypofractionation for breast cancer. Really, the excellent studies done that showed you can use essentially fewer days of therapy as compared to what people traditionally done. And for, breast cancer, often younger women who may be working, who may have families at home. So it's a big deal to be pulled away. The therapy is every day in sequence for weeks. So even, it's only 15 minutes of the day of actual therapy, but the driving, the parking, the time off to your point in time, and it's every day for weeks. You can do hypofractionation and shave off like 5 weeks of therapy with no change in outcomes. So no change in survival, no change in outcomes. Patients are more adherent. Obviously, it's easier to do fewer weeks than more weeks for the reasons we talked about, and there's less physical toxicity. You know what's crazy about this? Doctors are still not doing hypofractionation.
Why do you think that is?
I have my cynical answer and then my less cynical answer.
I like the cynical answer, please.
The cynical answer is we still have in most places a fee-for-service payment structure. So the more I do, the more I get paid. And I don't think it's always nefarious, but I think if you're like, well, this is what we've done for a long time, and I happen to get paid more for that, and maybe the money that I make from that actually goes back to patient services. Maybe it pays for my financial counselor and my nutritionist for reasonable good things, but still, there's dollars connected to more, it changes the way people behave. So that's my cynical answer. My less cynical answer is that it's very hard to keep up with, the data and the evidence. You get trained a certain way, and then you kind of practice like that for the rest of your career. It's pretty difficult to change physician behavior. It's difficult to change any of our behaviors, just to be honest, right? Like what we do day in, day out is what we do day in and day out. And that's the same in the medical setting. So that's my less cynical answer. It's just that people get into habits and they don't maybe rethink things like time toxicity, financial toxicity, and physical toxicity.
I wonder what you think of the idea. I have an idea that I think on some levels, doctors say to themselves, well, this is important and this trumps everything else. And there's not that they don't have perspective that this is someone's life. I think they think about their life in terms of, we've got to beat this condition at all costs, but not the cost to the patient outside of the treatment.
Oh, I was just working in the hospital last week, and what you're saying is so true. We're very unforgiving and poorly understanding. So there was a gentleman that came into the hospital and had terrible worsening kidney function. He was getting treated for cancer. And he said almost this exactly same thing. He was like, I just needed time away from you all. So even though his oncologist sent him to the emergency room to get admitted to the hospital, he was like, I'm leaving. I just don't want to do this. Like, unless you tell me I'm going to die right now, like, I just want to go home and I'll come back in a few days. And we, of course, were like, you're leaving against medical advice. And like, we make it seem so scary. And we do all these things to make someone feel guilty and bad for telling us that they just need some time away from us, which is terrible. We're supposed to be centering their needs. There is a way to be, again, creative and outside of the box. You can do labs, go home, we can give you some fluid, come back in a couple more days, recheck. I can do an outpatient study. I mean, there's a lot that we can do. We can do cancer therapy at home. We can do things like hypofractionation, but we don't, right? We don't think about all of the ways that what we're doing is difficult for somebody. We want them to accommodate to what we do, right? Instead of thinking about accommodating to what they need.
What does hypofractionation look like?
Yeah, essentially it's at the very beginning of making a treatment plan. You would say, look, based on this, characteristic of your cancer and, how severe it is and other factors, I believe that we can treat with fewer sessions than I traditionally would do. And that's kind of it. And then you just make the plan, and then the person only has to come in, again, like I said, the 5 weeks versus the 9 weeks, depending on the cancer type, et cetera. It's really no like big skin off of anybody's back. It's just a matter of like, do you think about it early enough on in the treatment phase, and do you make the plan accordingly? And so the data is most robust in breast cancer and in prostate cancer, but there's a few other cancer types where this has also been recommended. In COVID, during the pandemic, when we were trying to limit people coming in, the adoption in the US of hypofractionation went way, way up. But Europe has been doing this for a decade plus. It's just the US and our payment structure that probably has impeded the uptake here.
Can I tell you my story? So I carried a BRCA2 gene mutation. My mother died of metastatic breast cancer. And so what that means for me, as you know, is lots of visits to the oncologist, who's the team lead. Yes. And then, now I had 2 biopsies in the space of 6 weeks. Now I'm talking to the surgeon and the plastic surgeon. I mean, all of that stuff like really cuts into my time. I'm already extremely busy. And by the way, neither of the biopsies revealed anything. But the process has just worn me down so much that I've just decided I'm going to do the prophylactic, because I just want to get off this train. Like 2022, and I talked about it in many of my podcasts, the frustration with the whole process and the time suck it's been. I call it at the carousel. That I just want to get off the carousel, and I don't even have cancer. So my question then becomes like, how do doctors, how do they reduce time toxicity for patients? Because it feels like it's sort of built into cancer care and cancer treatment.
It is. I will say that I think things are changing. The pandemic really kicked us all on the butt as a health, system, in that we had to think creatively about how do you deliver services in different ways. So think about telehealth. I mean, specialty care really wasn't a huge adopter of telehealth. And in the system where I was working previously, we went from like pretty much 2% of all specialty visits being phone or video to 90% over the course of 2 weeks because we had to by necessity. And
Right.
it's sort of settled out in most systems, maybe 60-40 or something like that. But it took a global pandemic to force the health system to really start focusing on patient-centered care. But I do think some pieces are here to stay. Telehealth is here to stay. A lot of movement towards infusions at home, cancer infusions at home, teaching patients how to self-administer subcutaneous or, injectables. So we did that. I feel like that's here to stay too. And then I do think that the health system has to be kind of forced to think about payment reform so that those alternative sites continue to get reimbursed. Because right now, many of those things aren't, or it's under the emergency still. And so when those protections go away, we could backslide again.
I mean, it got to a point where I had to leave an appointment because the appointment just took so long. I was parked at a meter. The meter expires in 2 hours here in New York. And I said, look, I can't stay. And they're like, oh, no, you'll be here. And I said, no, you don't understand. My appointment was a half hour ago and I was here 45 minutes ago. So I'm leaving. You're going to have to reschedule this. Like, I'm going to need my copay back and I'm leaving, and I just wonder about people who don't have that. And I consider myself, having the luxury of time in some respects, even though I'm busy. But, I don't work at an office. And so I wonder about people who have this, who look at this and say, I can't do this. I've got kids. I've got my job. This is costing me a lot of time and money. And they fall out of the system. And then we sort of blame them and say, well, they're not prioritizing their care. But it's not that. It's that you've made it so difficult for people to get care and maintain the care.
You're 100% right. It's very frustrating. One of the oft, criticized behaviors of patients is that people will go to the emergency room for non-emergency things or go to urgent care, for non-emergency things instead of seeing their primary care practitioner. And to me, the reason is what you just described. Those care settings mostly are 24/7. They run on the weekends. You can get all of the studies done in one sitting, labs and imaging and whatever else might be done, and get your prescription at the same time. Most parts of the health system are not set up like that. So how can we blame folks for going to the most convenient, setting, even though it's maybe more expensive and not the level of care we want? If the consumers are telling you this is what I want, you have to make the rest of the system do that, or else people will continue to do that. It's just human behavior. It's why we like food to be delivered to our houses. It's not the cheapest way to do it, but it's the easiest for our lives. You know what I mean? So yes, 100%. And I'm not into the patient blaming behavior. It's not. We need to make ourselves better, right? The health professional has to clean up our own house.
Can you talk about community oncology? How's that different from traditional cancer care?
Yeah, and I don't want to make them sound binary or that one is traditional, because probably actually community oncology is like the OG. It's probably like the original way places that people got their care delivered. But essentially, it's the way you think about your primary care. Some people think about their primary care doctors. It's the doctor down the street that lives in your neighborhood, that knows everybody. Maybe they grew up there too. Community oncologists typically, right, or they're standalone, or maybe they're a multi-specialty group, but they're really embedded out in the community as compared to an academic medical center that might be more focused on research or grant writing and advancing the field of science. A community oncologist is really focused on care delivery, right? And hopefully in the most efficient way. So what we're talking about previously, the hour-long delays and the parking challenges and all that should be minimized in a community setting, because their whole point is to really think about how do we get people in and out and do treatment in an efficient way. It used to be that oncology was mostly community oncology. There's been a lot of consolidation in many spaces, but in oncology specifically. So practices got bought up by academic centers or other big groups, or sort of like ginormous oncology groups. And so the proportion of just standalone community oncologists has shrunk and shrunk over time. And I'll tell you the sort of dirty secret about that, which is that Typically, care delivered by a hospital system or a big academic center is meaningfully more expensive because there's a facility fee connected to it than the community oncologist. So whereas it seems better, like, oh, I'm going to a center of excellence, or, I'm going to this academic center. Yeah, there are patients that really need that. But if you're getting kind of run of the mill, basic care, basic oncology treatment, that is not the best place to get your care, and it's much more expensive.
And, to that point, I was going to say that, on the flip side of the conversation, I imagine there are a lot of well-meaning oncologists who do value the patient's time, but the system within that huge medical center, the medical system, as you were talking about, just doesn't allow for the prevention of or amelioration of the time toxicity. So it may not necessarily be the clinician. Sometimes it's the system that they work in that they don't necessarily, it's beyond their control.
Oh, usually it's beyond their control. It's rarely the clinician who is, at the crux of it. And so think about a community oncologist that has their own nurses, that has their own infusion center, that is sort of built around the care as it should happen from end to end, versus someone who has a shared set of nurses, shared infusion center, shared imaging center, where it's not just oncology patients coming in, it's rheumatology and it's GI patients. It operationally is much more complicated, and that leads to, variable experience.
What do you think is important for clinicians to understand about cancer patient care?
I think for me, the front of mind thing is there's been amazing progress. The death rate, the mortality rate from cancer has gone down. Some of that is from just fewer people smoking, but some of it really is from amazing advances in the field. I will say that we still have huge gaps in terms of outcomes for certain populations. We still have huge gaps by race, ethnicity. Black patients, Latinx patients have, every step of the way, poorer outcomes. They don't get transplants at the same level. They don't get the same surgeries, reconstructive surgeries at the same level. I mean, the gaps are really persistent. And so I guess I would challenge us as clinicians to do a little bit of looking in the mirror, which is like, we can celebrate all we want, but if there are groups of patients who have not benefited equally from those advances, is that really progress? So I think that's what I want people to think about, is how do we actually deliver the best that we have much more equitably?
That goes with that same goes for the research as well. Like a lot of people who could be, because the thing is, you create a drug and the drug is only based on a small subset of the population, and then you later find out it doesn't work for other patients, then have you really done your due diligence? You haven't, right? But they use criteria to exclude people who should be part of these. Why not change these criteria? That people of color tend to carry a little more weight. Don't make that a reason for them not to be admitted into the trials. I get that you want perfect results, but if you put a drug out on the market that doesn't help with these people, then you haven't really done your job in terms of creating a drug, right? Like
you asked the hard questions though, right? Whose job is it there, right? And again, I'm not anti-pharma, but pharma feels like they did do what they needed to do from that perspective. It did work. They brought it to the market quickly. I think the onus is on us as practitioners to start to question that. And I think from a regulatory perspective, we need the FDA to demand certain things. The clinical inclusion criteria has to look like the population that we serve. We can't be excluding hypertension and obesity, things that are incredibly common for everyone and more common in certain populations that are at risk. So I think there's a bit of regulatory oversight that needs to change. And then I think we as clinicians need to be a little bit more skeptical. That new drug wasn't studied for that patient. So don't use it for that patient, because that's actually kind of experimental. You don't know if they're going to benefit from it. And to our earlier conversation point, what's the cost to them? Time, physical, and financial.
Well said, Dr. Soni. Thank you so much. I've been waiting for this. I've been mentally salivating, waiting for conversation with you. Thank you so much.
You are so welcome. You're really an inspiration, and you're living so much of this right now that I think your perspective really will make us better as a health system. So thank you.
Thank you. Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.